My name is Frank Cohen, and I'm the Director of Analytics for Doctors Management, a Knoxville, Tennessee-based healthcare consulting firm. I'm a healthcare consultant, and I specialize in applied statistics and predictive analytics with a particular focus on compliance risk and post-audit damage mitigation. The truth is, no one can predict the exact probability of getting audited, as to do so requires data that are simply not available to the general public, so don't be fooled by those claims. What we can do, however, is to assess and prioritize codes, modifiers, and providers, not by some exact prediction, but rather by using the same advanced statistical techniques that are used by the auditing entities to profile individual providers and claims. In this presentation, I'm going to go through the backstory behind CRA, our risk-based expert system, explaining how the government has precipitated the need to step up the game when it comes to quantifying the risk of an external payer audit. Now, to begin, we want to know why payers have become so aggressive when it comes to recovery audits. And the answer is, not surprisingly, money. The whole purpose of recovery audits is to return as much money as possible back to the trust fund. In a report recently released by CMS, they claim through the use of advanced technologies and program integrity strategies to have prevented some $28 billion in payments to healthcare providers, in addition to the $15 billion taken back in recoupments and other investigative penalties. Now, according to the most recent CERT study, some 12.7% of all Medicare fee-for-service payments are made in error. For physicians alone, this translates to nearly $50 billion when accounting for private as well as government payers. Now, this success has created increases in the budget that CMS has to move forward with its program integrity strategies. Now, prior to 2011, auditors relied upon arcane techniques such as random probe audits or utilization benchmarking to ferret out improper payments. But these methods created so many false positives, it resulted in a very poor return on investment for the payers. So in 2011, CMS introduced the Fraud Prevention System, or FPS, which consists of a series of predictive analytical algorithms designed to identify high-risk providers. Beginning July 1st of 2011, 100% of all Medicare fee-for-service claims, including all of yours, are passed through these algorithms prior to payment. I start this by asking what payers are looking for, and not just CMS, because depending on which study you read, private payer audits account for some 28% to 33% of all physician audits. In general, there are 4 issues that are in the spotlight. Mistakes, which are made up of simple errors. With the complexity found within the coding guidelines, it's quite common to see coding errors. These might include transposed procedure or diagnosis codes, computer errors, or incorrect data items, say as a modifier. Inefficiencies will often create financial waste, such as medically unnecessary services or improper diagnoses, or even systematically bad coding and billing practices. Now, the bending of resources often results in accusations of abuse, which really changes the game. Here, we see such practices as upcoding, improper referrals, use of unlicensed staff, etc. When intent is shown, fraud rears its ugly head. Examples are billing for services that were not provided, intentionally unbundling services when it is clear that it is not permitted, or maybe altering medical records and the like. For the most part, fraud accounts for around 3% of healthcare spending. Errors and waste are more difficult to identify, which is why CMS has turned to these advanced technologies. The government payers are supported by many different auditing entities. It's important to understand that while all of these entities share a common goal to return as much money back to the government as possible, all have different missions, incentives, and motivations. For example, RACs are paid a commission on the amount of money they recover, somewhere between 9.5% and 12%. So a RAC may focus more on RVUs at risk, since these can be converted to dollars pretty easily. A ZPIC, on the other hand, normally takes its lead from another agency that suspects fraud and/or abuse, as that is the mission for the ZPIC. In that case, they may be more interested in frequency. All of these agencies have access to data that no one else does, and they share their findings with each other, giving them advantage over providers. Private payer audits share many similarities with government audits. They both have a goal to prevent improper payments and recoup monies that they believe were paid in error. For provider For private payers, audit rules may be tied to specific contractual issues or limited by state law. But unlike Medicare, there isn't a lot of transparency with regard to specific guidelines, so rules remain a bit nebulous. One major difference is that private payers can review as many charts as they want, as long as their request doesn't conflict with any contract or state laws. And because of the government's success, private payers rely upon CMS and government rules and payment policies when it comes to applying overpayment calculations. For medical practices, there are 5 major categories that are considered by auditing entities when profiling a practice, and therefore by us when conducting a pre-audit risk assessment. Evaluation and management codes are such an easy target that pretty much every audit entity will review them. In my experience, however, E&M codes make up a small percentage of actual overpayment damage estimates, which seems to be a bit counterintuitive to many folks. Rather, it's non-E&M procedure codes that account for this larger portion. Perhaps that is because the average payment amount for, say, surgical procedures is more than what one would find for E&M codes, and due to the complexity of even a single event, many procedure codes may be involved. Also, ZPICs like to focus on frequency of improperly paid claims, as they can generate huge recoupments in the form of civil penalties. Now, RACs tend to look at situations where there would be a lot of RVUs at risk, since they can easily be converted to RVUs or into dollars, and they are paid a commission on the amount that the claim is overpaid. And private payers focus on RVUs to identify physicians that are in higher cost categories, which is a precursor to audit risk. Of late, modifiers have popped into the spotlight again, and it's more than just modifiers 25 and 59 as it was in the past. Lately, we've seen audits include modifiers 24 and 78, and I expect this to expand in the near future. Finally, payers, using the RUC time study, conduct analyses to determine whether the number of assessed hours a provider reports is reasonable and believable. So if your providers are reporting very high hours per day, it is likely that they have garnered the attention of the OIG. In doing some research, I came across a report that was published by CMS on their program integrity efforts. It lists the different types of reviews that CMS performs. For example, an automated review is where a computer algorithm processes large numbers of claims looking for obvious issues, such as missing demographics, or no diagnostic code, or even a violation of the NCCI edit policies. A semi-automated review is where a human operator may dive deeper into some anomaly that is reported in the automated review. The complex review, however, is the one that most of us are exposed to in our practices. This is where we get the letter asking us to submit documentation to support claims that have been paid, and a coder or auditor does a physical review based on documentation and medical necessity guidelines. Now, notice the number of claims subject to the automated review is pretty close to the number subjected to a complex review. But then notice the actual dollars recouped. Automated, $96 million. Complex, $2.3 billion. Complex reviews accounted for 93% of recoupment. That's huge, and that's why no one should expect anything less than continued increases in audits from all payers in the future. So let's take a minute to talk about this idea of how the process works. In automated reviews, using the fraud prevention system and other advanced statistical models, individuals as well as groups of claims are scored based on the likelihood that they may meet the criteria for fraud, waste, or abuse. The claims that end up with a high score are subject to a semi-automated review. Here again, the auditor can review some retroactive period for all claims of that provider or group, and in these cases, they are looking to identify potential patterns or outliers which could translate to fraud, waste, and abuse. Then, before determining whether to audit or not, the auditor will often conduct an expected value analysis. This helps them to determine whether the likely return on investment is enough to warrant conducting a focused review. Currently, for every dollar the government invests into an audit, they get $12.40 in return. If the return on investment is sufficient, then you can expect to receive a written request for specific medical records, which begins the focused review. Now, comparing benchmarking to predictive analytics is like comparing apples to oranges. While benchmarking may help identify the obvious, the problem is that the majority of recoupments arise out of nuance, which benchmarking often misses. This is why CMS now relies upon predictive models as a major part of their program integrity strategy. There are several different standard approaches that practices take when trying to assess the potential risk for an audit or review. The most common has been the probe audit. This is a random pull of some number of charts per provider over a period of time. And this is perhaps the worst method of all. Imagine this. A typical provider bills for some, 75 unique procedures a year. Even in an aggressive organization, normally the upper limit for review is 30 charts per doc per year. So expecting to get 30 unique procedures from those 30 charts would exceed the odds needed to win the lottery. And it starts you off by missing 60% of the potential risk. Remember, the purpose of a probe audit is just to find areas of risk, requiring an additional audit of those risk areas after the initial audit. Another common technique is the comparison of rank position for a given code to some control group. For example, you may look at a data set that shows the rank order by frequency of utilization for codes for your specialty and see that both you and your peer group report the same code in position 1, meaning that you both report this procedure most often as a percentage of all other procedures. This fails because it does not consider variance. Maybe you and the benchmark have the same top code, but if you report this code twice as often as your peer group, that vital datum is not visible. So a lot of folks just look at variance, but without considering frequency, there isn't much value. For example, what if I told you that a provider coded all of their established office visits as 99214s? How many of us would consider that to be a problem? Well, what if I told you that they only reported 2 established office visits during the whole year and that both just happened to be a 99214? Now it's not a problem anymore. Frequency alone without variance creates substantial false positives, which suck resources from codes that really do present a risk. The most effective method outside of predictive modeling is to multiply frequency times variance and consider the higher the value, the higher the priority. It's not risk, but it's better than nothing. One problem is that the math breaks down at high variances and low frequencies and ends up creating, again, a lot of false positives, which again reduces the value as it adds cost and waste to the process. So in the end, all we're doing here is creating a smell test, which falls far short of the most efficient and effective compliance strategy. And there is no doubt that with the introduction of the fraud prevention system, CMS has raised its expectations with regard to the sophistication level of an organization conducting their own internal reviews. There's no question that trying to assess the risk of an audit is a complex undertaking and requires a high degree of analytical skill as well as very advanced tools. Add to this the need to differentiate between what you look like to an outsider and what constitutes real risk, which can only be assessed after conducting a chart review. To date, our CRA application is the only expert system that uses real predictive analytics to create a risk-based audit plan for your organization. So here's how it works. First, it's important to understand that benchmarking against the Medicare database is an integral part of CMS's fraud prevention strategies. It falls into the law of large numbers. Relying upon the 2.6 billion fee-for-service claim lines, Medicare data are used to establish a baseline utilization for some 16,000 procedure codes in over 75 specialties for some 800,000 physicians and remains the steadfast component of the risk model. But to calculate risk, one needs to be able to factor variance from cohort groups, and that is what we do exclusive to anyone else in our industry. Using a database that contains nearly 100% of all claim data for some 250,000 providers and utilizing some very unique and advanced sampling techniques, we are able to create a perfect average physician in nearly every specialty and taxonomy in the marketplace. Now, like everyone else, we start by comparing the utilization vectors for a given event for each provider in their specialty against the utilization vectors for that same event for that same primary specialty using the Medicare database. Let's say that your doc reports procedure code X, 8% of the time, and the benchmark is 4% of the time. The question is, does this constitute risk? And the answer is, nobody can know at this point because risk cannot be calculated in this linear a fashion. It requires a cohort. So we then compare those same utilization vectors against the same benchmark using our cohort group. Then we conduct an analysis of those variances, which is a major component to modeling risk. So let's say our cohort doc also reports this procedure 8% of the time. In that case, there wouldn't be any risk. And understand that this is a very simplified explanation. Because as a true predictive model, we also rely upon the use of both supervised and unsupervised learning techniques to create our predictive algorithms. So let's say you're driving down a road that has a 65 mile per hour speed limit. This is the equivalent of a Medicare benchmark, say that 4% utilization example. Now, if you're driving at 65, the speed limit, and you pass a police officer, what do you think the chances are of getting stopped? Well, unless you have a taillight out or you're doing something crazy, the chances are pretty much random. Now let's say you're driving at 80 miles per hour. What are the chances of getting stopped now? Well, it's pretty difficult to give an exact probability, but I think that most folks would agree that the chances are, at the very least, much higher. Finally, let's say that everyone, including you, is driving at 80 miles per hour. Now your chances of getting stopped go back to random. In this case, you're being sheltered by the flow of traffic of the other vehicles. And that's how our cohort component works. In essence, when we look at what your docs are doing, we're using the cohort to measure the flow of traffic, if you will. The end result is the creation of the audit action plan, the ultimate goal of any billing and coding compliance program. The audit action plan is a document that for every provider that has been identified as having a risk in any of those 5 categories that we mentioned above, lists up to the top 5 risk events, which are procedure codes and modifiers. And remember, we also include time. So the risk score assesses the likelihood of an audit, while the audit action plan identifies specific codes and modifiers that would most likely be the target of an audit were one to occur. Finally, the CRA application now includes its own robust audit documentation, tracking, and analytics package called the Audit Tracker, which is used by our clients to manage, monitor, and analyze in a real-time environment the progress of ongoing audits. As it is integrated into the CRA, the Audit Tracker creates a feedback loop, working as an intelligent assistant in monitoring your audit progress, saving a ton of time, money, and resources in trying to match one system to another. So let's talk about the benefits of the Compliance Risk Analyzer. Perhaps the number one benefit of the CRA application is that it reduces the very complex problem of compliance risk assessment to a very simple and easy to understand solution. Unlike most applications, including EHRs, practice management systems, and even audit repositories, it takes less than a day's training to qualify on CRA, which results in a much lower cost to the organization in both manpower and dollars. And while the CRA is scalable to any size practice, it is definitely optimized to be most efficient with much larger practices and provider organizations. Unlike probe audits or utilization studies, CRA conducts a statistical analysis on 100% of claims, something unachievable until now. It also lets you see what you look like to an auditor before an audit occurs. Using the audit action plan, CRA results in precision identification of which charts should be audited. And rather than have to purchase another software program or create one on your own, CRA includes an integrated audit documentation, tracking, and real-time analytics package. Finally, to make life easier on everyone, from the physician to the analyst to the C-suite, CRA results are presented in a simple and elegant format. For more information or to set up a demo of the application, please feel free to contact us at the phone number or the email address below. If you'd like to see a demo of the application, you can go to www.complianceriskanalyzer.com and click on the CRA application demo link. If you would rather look around at the application on your own from the same website, click on the Take a Tour link. Again, thank you for your time, for taking the time to review this presentation, and please do not hesitate to contact me with any questions that you may have.